given at the end of the presentation. So we like to have at least 20 to 40 countries each lecture presented, being here with us. And we have obviously presenters from all over the world previously coming here. So we have Argentina, Israel, Greece, USA, Romania, Malaysia, Germany, Philippines represented already. So if you're in another country, put it in so we'll know where you're from, and we also know how far we are reaching and teaching with the free monthly educational webinars on SSOL. We're going to wait for another 2-3 minutes until everybody's arriving. And we welcome you. If it's your first time, great to have you here. And of course, all the returning guests are waving hello with their hands and putting in the country would be great. I do remember you guys, but not everyone, of course. We have over 200 registration this morning. Usually we have close to 3, but it's a different day today, Sunday, so that might be a family day many places. So it is recorded, and anybody missed it, we will send you the link. If you already registered, you have direct access. So welcome from Bulgaria, United States, Argentina, Israel, Greece, Romania, Malaysia, Germany, Philippines, Canada, and make sure that you are adding your country on the bottom. And welcome you for the School Assistant Spine online learning. We're going to wait for another couple of minutes until everybody arrives to this very special summer session. And we're going to have another summer session next month. Make sure you write it down July 13th at 10 a.m. And we're going to have a little summer break after that. So please feel free to add the questions. Hello from Cyprus. Thank you for putting in your location. Very regular visitor here. And we welcome you from many, many parts of the world. That's our mission, reaching and teaching across the globe, providing free monthly education on a scoliosis and spinal disorder topic, which is really, really expanding, and research is coming in every single day. So we try to keep you up to date with the latest research, the latest treatments at SSOL. So we're happy to have you back and happy to have you the first time here. I'm going to share my screen just to give you a little bit of introduction to our program. Scoliosis and Spine Online Learning was founded in 2018. You can see the two co-founders, myself, Angela Bell, and Dr. Hagit Berdyshevsky. And our mission was to provide education around the globe, free monthly webinars, and of course, invite you to either the Schrott Method or Leo Method certification courses and build you a very, very large library. The library is there for you 24/7 open, and this library is accessible from around the world. We have over 160 lectures here from experts around the world, and you can come in and learn anytime from anywhere. You can also sign up for our certification courses in many different topics, but mostly the most popular is the Schrott Method certification. You can check the pathways and the upcoming courses. And Leon Method is 100% online. We have students from 5 continents already enrolled into this program. So you can check that out as well as our library at any time. And we welcome you to check out our new educational team from the Schrott Method, as well as the global presenters. So you can visit our international educators, which are certifying physiotherapists and PTAs around the world. And we are happy to reach out to anyone who would like to host the courses. And you can also check the upcoming courses here. So I would like to welcome you everywhere, wherever you're coming from, into School Assistant Spine Online Learning. We are happy to have you here. And we are continuing our monthly free webinar series. Now it's the 8th year, and every single lecture has been recorded and added to the library, so please visit us often in the library. And would like to introduce Dr. Hogit Berdyshevsky, who's going to be introducing our speaker tonight.
Thank you, Andrea, and welcome everybody. I'm going to share my screen for that. Oopsie. So I'm very happy and honored and always great to see you, Dr. Baron Lohner. And this time it's about a hot topic and also upgrading research, which I will leave it to Dr. Baron to talk about it. And it's about the vertebral body tethering, the treatment for scoliosis, of scoliosis, rationale, result, and the future. Dr. Baron Lohner is the director, scoliosis surgery and pediatric spine at Spine Associates in Manhattan, New York, and also a clinical professor of orthopedic surgery, I don't know how to say it correctly. Icahn School of Medicine in New York. And on a personal level, I met you. I met you in I think somewhere in 2009 or 2010. Yes. We met Baron and I at one of the missions of Dr. Buachi and the surgical team in Ghana, Africa. Those who know me, every lecture I usually begin with the history of what brought me into the world of scoliosis, and this is volunteering with Dr. Buachi from HSS, who used to be at HSS, now he's completely in Ghana. And Baron and I think we met one time, maybe twice, I'm not sure. And Baron was he is one of the volunteering surgeons traveling to Ghana and helping those kids with severe complex spine deformation or conditions. So, and a good friend and always available to any question at any time. This is a great relationship to have for all the physical therapists here. And I really enjoying having someone like you in, I can't say close proximity because we are now living, I used to live one street from his practice. Yes. But now I'm in Israel, but you are in my heart and you are with us, and it's just wonderful to have you as a collaborative and always answering and ready to help the community. This is an amazing side of you, a side of your excellent skills and surgeries and progression with this VBT, but it's really amazing to have a person, a doctor who is a person first of all. So I will give you the sharing of the screen, and thank you for coming on to this hot topic.
Hagit, thank you so much for that very kind and open introduction. It's terrific to be here with all of you. And I congratulate you and Andrea for this SSOL platform that you've created and the terrific educational content. And I would just tell you, as I talk to patients, I say, hopefully I'm skilled, I have hands that work well, and I have good technical skills, and I have proper indications. But when your daughter or your husband or wife is in my operating room, they're my family. Your daughter's my niece, your son is my nephew. And I think for all of us, and I think physical therapists are very hands-on. You spend a lot of time with your patients. The families really appreciate that hands-on and close, compassionate care. And so what drives me in this topic is really thinking about my patients as if they were my own family. So I've done thousands of, this is my 30th year in practice, and I've done thousands of spinal fusions. And those cases you showed in Africa there with those terrible, bad severe scoliosis and the body shape changes for the patients. there's no choice but to do spinal fusion in those patients. But we take a lot of otherwise healthy young patients, adolescents with a curved spine, but they're healthy spines, they're just curved. And we lock them up with a fusion. And I now see my 20 and 25 and 30-year follow-ups. They don't all look so good. Now, some of them do very, very well, but I think we can do better. And that's really what drove me in the past decade to take this topic and this approach to many of my patients. And we've pushed the envelope a little. I'll share some of that with you. And I would just say that I partner very closely with the Schroth therapists. I don't think we have the Lyon technique here in New York, at least that I'm aware of. But I work very closely with a handful of or a group of physical therapists. So it's been a great relationship. So the one most important disclosure is that I do get royalties as a surgeon who helped to develop the tether implant. It's now under the High Ridge company. It used to be ZimV and Zimmer. So as I was just saying, we take these young patients who are essentially, they have healthy spines. They don't have degenerative disc disease. They don't have facet arthrosis. They're just curved. And the standard operation is a arthrodesis or a spinal fusion. And we can, if we can get them to be a curve that is moderate at the time of skeletal maturity, we can maybe delay treatment. Don't necessarily have to offer this in the adolescent, but I can show some data on that because the operation later in life is much bigger if needed. But this is what we do. We dissect the spine, we move the paraspinal muscles aside, as you see here, and then we put the metal rods and screws in. And these patients have 50, 60, 70, 80 years ahead of them after being fused. So the natural history of that fusion is largely based on how low you fuse. So the lowest instrumented vertebra. And I'll show something on that. So that's this. So we did a study, about 100 patients, adolescents at the time of surgery, fusion, 10 years later. So these are now patients largely in their 20s. And if you fuse to L4, 1 in 4 patients in their 20s now will have significant disc degeneration. If you fuse to L3, 10%. And this all accrues over time. So, certainly fusing into the lumbar spine is not ideal for the patient. And this is an example. This is my patient. I saw her about 2 years ago. She's now 25, but was 23 at the time, 11 years following surgery. So we did surgery at age 12 years. And she presents with back pain and functional limitations, nice and straight. But here are the Scoliosis Research Society questionnaires, 5 being the best score, 1 being the lowest. And she's already got pain and diminished activity. She loves the way her back looks, 5 out of 5, satisfaction 5 out of 5. Super, super nice young lady. And I feel terribly about this because she's got already back pain and we fused to L4. That's where we had to go at the time. This was the only option I had. And I'm going to show a lot of mix and match approaches where we can at least save the lumbar spine, if not the thoracic as well. And this is what drives me to try to do better. And we know that even after spinal fusion, Michelle Marks, the first author on this study that was a multi-center study that we were involved in. Michelle is a physical therapist, and some of you may know Michelle. She's the executive director of the Setting Scoliosis Straight Foundation, and she's passionate in our research efforts on behalf of patients, and basically showed that after a fusion, the patients make up for the loss within the instrumented segments within the fused spine because they become hypermobile by becoming hypermobile below the fusion. But that's probably why, when they're hypermobile, that's probably why they develop the disc degeneration. And it's not a normal motion. I'll show you a video in a moment. So when I look at these patients, they come to see me, I say, well, obviously we want to preserve life expectancy, but most adolescent idiopathic scoliosis, AIS, it's not life-threatening unless the patient had the most severe of curves. But if it was earlier onset, either juvenile or infantile, then some of these patients will have very significant pulmonary decline and their life expectancy is potentially affected. We want to minimize complications of whatever procedure we offer. Obviously, I'm talking about surgery, but so these patients, some of them have failed bracing, some have failed physical therapy and bracing, and now they go on to surgery. The patients really want their body shape, which I'm trying not to use the word deformity, but they want their body shape to be improved, and they want to be taller in some cases. Sometimes they don't want to be taller. But for me, the pinnacle of the pyramid is to preserve motion and flexibility. Hopefully, we're all on the same page there. I suspect we are. And this is kind of, you know, you may find it interesting. We used to put these in Harrington rods. That's what the Harrington rod looks like. It's a hook up and a hook down. That was, I didn't put those in. That was, the last cases were done in the 80s. But then, you know, we've had an evolution of the types of implants that we place. And about 20 years ago, we were doing thoracoscopic fusions through very small incisions on the right side. And the advantage of these were we did shorter fusions. We did less levels than if we were to do a posterior fusion as here with pedicle screws. And then we got to tether, which is here. So we placed the screws identical to what we did for fusions those years ago, but now there's a flexible cord in there. Okay, so fusion is not physiological. It's not what we were designed for. So it should be just a salvage operation. Here's a Harrington rod again, and these were used for post-polio, very severe cases as a salvage. So they weren't operating on the milder, moderate, more moderate cases at the beginning. And you know, we rarely, as orthopedic surgeons, rarely do hip or knee fusions nowadays. I told you earlier, we can sometimes delay the case, right? We can delay surgery. Here's an adolescent we operate on, and standard fusion here. It's much shorter than if you let this play out over the course of the patient's lifetime and you get to them decades later. The fusions are much longer, including to the sacrum and with pelvic fixation. They're longer because there are secondary degenerative changes in the lumbar spine. So if we can impact that natural history and get to them sooner, especially with a non-fusion approach, I think that's quite desirable. If we operate on the adult, the major complication rates are 5 times greater than for the adolescent. And reoperations are about 3 times more often after that surgery. So it's, you know, in some ways we like to do this surgery earlier, but again, fusion has its own natural history. So here's just a comparison. We looked at patients side by side with similar curves, and we found, more levels fused, longer surgeries, so 7 levels more fused, 4 times the amount of blood loss, et cetera, et cetera. 15-year-old versus a 55-year-old. So it's a big difference. And this is a nurse that took care of my patients for years at one of our hospitals. She's a pediatric nurse, and she said, of course, no one else is going to operate on my spine but you, Dr. Lahner. So she came to me at age 62. She loved being a nurse, and the only tool we had available, especially given that she has a lot of degenerative changes in her lumbar spine, was unfortunately to do this big, I think it's a monstrosity. I mean, it looks nice and straight, but I really don't enjoy doing those cases anymore, and they're very high complication rates. Unfortunately, she had to retire because of loss of mobility and just it's a big hit. So I think for the reasons I outlined, to avoid problems below a fusion, to maintain normal or close to normal flexibility, I think especially for the lumbar spine, doing a thoracolumbar tether makes a lot of sense. And we'll talk some more about it. But also just a selective thoracic fusion where we leave the lumbar spine largely alone. They're not perfect. This is a young woman I operated on as well. And maybe we could have done a better job of kyphosis restoration back then, because she's got cervical kyphosis, maybe a little hypolordotic, but she's got severe neck and low back pain. And we sent her to our Schroth therapy friends in locally here. But these aren't perfect always. And here's a patient that one of my senior colleagues operated on 25 years previously when she was 15, and then developed secondary degenerative changes. And the salvage for that is we had to extend the fusion down and lock up the rest of her spine. So we're trying to avoid that, and that's why I push the envelope and look for solutions that can be controversial, and I'll show you some of that. Also, when you fuse down to L3, to L4, even L2, there's less return to athletic participation or to the individual's prior sport. So, we want to try to preserve their activities. So the ultimate procedure corrects the deformity, the curve, preserves pulmonary function, growth, flexibility, would have a low complication rate and high reliability. And that's maybe where the vertebral body tethering is somewhat controversial, and there's been some difficulty, and I'll speak to that. I think we're getting better and better, and I'll show you data on that. And the recovery, no question, is much faster with a tether versus a fusion. This is my first vertebral body tethering patient. We did a bilateral approach for a double curve. She's a lacrosse player. She's now just graduated college. And I operated on her 10 years ago. So my first case of this was 10 years ago. And I wasn't the first surgeon on this bandwagon. I was a little concerned that it was going to fall apart, that it wouldn't go well. And so I held back a little, but then I've since become very enthusiastic about the approach. And this is her. Bear with me for a moment, but she's 3 weeks now, just at 3 weeks following surgery. And our fusion patients are very sore. They're pale, they're uncomfortable, and she's pretty comfortable already at 3 weeks. Now she's a little stiff, so she's not bending normally there if you look at her spine. But I guess my point here is to show the ability to move much faster than what we see with a fusion. And the promise of vertebral body tethering then is that it is motion sparing. It is associated with shorter recoveries, less blood loss, and we don't burn any bridges. So the fusion still remains an option if for some reason it doesn't work out later in life, for example. And perhaps there'll be less adjacent segment degeneration below, as we see below a fusion. Time will tell. We don't have that data, of course, because we need the longer follow-up. But here's an example. Here's a patient of mine whose father is an intensive care director of an intensive care unit in New York, and the family sought out a non-fusion approach, analogous to hip and knee replacements. And here she is 5 weeks after surgery. My fusion patients don't do that. So, of course, I told them to hold off with activities until 6 weeks, but mom was a little exuberant, but she looked great. I mean, she's done very well. She's about 8 or 9 years out now. Some have called into question, does the tether really move? Is there really a preservation of motion, particularly in the thoracic spine? And I think this paper by Noel Larson's group clearly shows that there is at least some preservation. So the arc of flexion extension normally is 30 degrees, and here they're preserved 21 degrees. So there's motion, may not be quite normal, but it's a lot better than with a fusion, in which there's no motion. And then another paper by Noel's group looking at lumbar vertebral body tethering. And you just see that in the coronal plane, yes, pre-op is the yellow, orange is post-op. So there's some loss in the coronal plane, but still some motion. And you would expect it to be lost in the coronal plane, especially away from the tether. But also flexion extension 30 degrees is preserved. So better some than none, at least in my book. And if I were faced with this decision, I'd want that. There's a cadaver study. We don't have to get into all the details. Essentially, the cadaver study looked at double row versus single row, and also a fusion at the apex. And essentially, flexion extension and axial rotation were largely preserved. There was a diminishment in lateral bend away from the tether by almost 50%, but flexion extension and axial rotation largely preserved. And then this study out of Turkey just shows that the range of motion compared to fusion is much better, and trunk endurance as well. We don't have to get into the numbers, but basically if anyone wanted to review this, you'll have this online. You can always review the paper. Here's a nice patient of mine, and she was nice enough to do this video for us. I fused her a number of years before, and we asked her to do some range of motion for us. So,
Okay, great.
and you can see it's like a diving board, right? She's moving below, and in her hips. Axial rotation looks okay, but it's really, really quite not a normal motion. And then here, there's really not much lateral bend at all. So, and then, and here's a patient that we did a bilateral tether on, and I think you'll see it's somewhat better. Much better lateral bend, especially there, you can see. And then here, and you know, I think you can see there's motion within. So it's a very different operation. This is a kind of a collage of the patients that gravitate, the families and patients gravitate to this motion sparing procedure. Dancers, swimmers, whatever, even people who aren't that active. But we have to consider a lot of factors when we indicate the patients, the size of the curve, how flexible it is, location. So we might be more aggressive in terms of stretching the indications for lumbar scoliosis, whether they're involved in sports or dance, their maturity, so how much growth is left. This is really a growth modulation procedure, it's called, and I'll show you that, but we've pushed it in even mature patients, and I'll show some data. And also, what's the family philosophy? If they want something that's just one and done, reliable, locked in, that's going to be a fusion. But if they want something that preserves more normal physiology and function, that would be the tether. So it's probably not a good option for very large curves, very stiff curves, and the ideal patient has growth remaining. With little or no growth, they're not going to be able to grow straight over time, which is a process called growth modulation. But we've been applying this in more mature patients. We think there may be some remodeling of the discs, perhaps of the bones. And, you know, we really spend a lot of time discussing these factors with the families, especially when we're thinking about a more controversial indication. But for this patient, there's probably very little role for a motion sparing approach. However, I think today, this is an older case, I think today I'd probably offer the family a shorter fusion. I would say maybe we could fuse to T12, maybe even T11, and then tether below. So we save more motion segments. So we're really trying to save segments where we can. But you know, you see a very good outcome in this patient. So the ideal patient has curves between 40 and 65 degrees. And some of you may be treating these patients because the families are trying to avoid surgery, which is, you know, understandable. So you probably will see some of these patients or do. And then, you know, they have growth remaining. So we use the hand x-ray for Sanders score. The ideal is probably 3 or 4. But essentially at just before, just after the growth spurt. But again, after the growth spurt, it's really managing the spine. We're not trying to fix it. We don't provide a cure, but we're trying to preserve function, and we're collecting data on that. So, but this is kind of the ideal patient, nice and straight, at first erect. Some of the screws look a little tilted. That's because we're going around the ribs, so we get the best trajectory we can. And then he grows straight over time. And then you can see some splay here of between the two screws. That's because he broke the tether there. But that's fine. The tether breaks, it doesn't move around the body. It stays put, the spine is stable. He doesn't go flying. He's not spring loaded, this young man. and he continues on with his life. And he's got a nice, fairly good-looking spine at this point. And here's another patient with very nice outcome. So, and if the tether breaks, that's fine, um, unless they didn't have a chance to remodel or grow straighter. But also you see excellent improvement in body shape and excellent function, butterfly. So this procedure was developed, as was stapling. Some of you know about the history of vertebral body stapling, but the tether's placed here, and the idea is to control growth, decrease growth on the convex side of the curve, and stimulate growth on the concave side, so they grow straight with time. And this comes out of the work by the seminal work of Ian Stokes. Who was, maybe still is, in New Hampshire at Dartmouth, and he would apply these asymmetric loads to the rat tail, these mini external fixators, and would basically create scoliosis. So the rat tail is analogous to the human spine, and he would load it asymmetrically, and because of the asymmetric growth that would occur, curves would come about. And then he would apply the fixator in the opposite direction, and in time the vertebra would unwedge, and they would grow straighter. And this led to, even before that work, there was attempts at stapling. This was in the 50s, didn't work out very well. And then there were more modern attempts with animal studies, etc., for stapling. And we did some of these. I wasn't very enthusiastic after just a handful of these cases, because the curves had to be relatively mild in order to be successful. But this is a great successful case. This patient had a stapling and pretty nice flexibility of the spine without a spinal fusion. But often they didn't work, and we had to do these fusions to salvage it. So then came more larger animal models. Peter Newton was a leader in this, and he created scoliosis. He would apply in the calf, he would apply single or double tethers versus a control, and he created scoliosis by doing that. So it would result in asymmetric growth, and the double tethers had greater mechanical advantage, so the curves were bigger. And this is what it looked like: single versus double on the right, and a sham on the left, so just a control. And then the water content was preserved within the discs of the tethered portion of the spine. Proteoglycan content was largely maintained, in fact, increased even. And then the collagen types were slightly different compared to control. But the disc was maintained, narrowed on the tethered side, but maintained in a healthy manner, at least for the follow-up of these animals. There were other models that were done. Frank Schwab's team, they created scoliosis and then they applied a tether. So this is in a porcine model. And then what they found is that they were able to correct the scoliosis and improve kyphosis, and even improve the axial rotation, the twisting of the spine, and improve the wedging of the vertebra. So again, more models that prove the concept. And then the first case was done about 15 or 20 years ago. It was a one and done type procedure because there weren't many cases being done at that time. That was the first, but there weren't a lot of subsequent cases in that time frame. But this is an example of how a patient is corrected and then grows straight, and he started overcorrecting. And that's one of the problems of this procedure. So that tether had to be removed with a really nice outcome. The first, at least in the United States, the FDA approval occurred in 2019. And it was probably a similar time frame for Europe as well. And this is kind of what this is what the implants look like. There's a tether. We tension to get correction, but we place this, it's basically a rope made out of polyethylene. It's a flexible rope. And we do this through these very small minimal incisions. We use a 5mm scope. Now I do this 2-inch incision, or 4 or 5 centimeter incision, and then a 15mm incision here. And we can cover T5 to 12. And we do these thoracolumbar approaches, T11 or T10 down to L4, through a 10 centimeter incision, or smaller even. And then, this is kind of what it looks like in surgery. The lung is here, it's deflated, the rib head's here. We place our screws, and then we tension, and this is what it looks like in surgery to get correction. So there's not very much bleeding, very little bleeding actually. And then you see at a year, this wedged vertebra here now becomes more rectangular. It squares off. So with growth, we get that really significant growth modulation. And that's the premise of the procedure. Here's a patient, larger curve. And because we tackled this early on, we were able to get a lot of correction. And she's now 8 or 9 years out. But we had a really good correction. She overcorrected here a little bit. So we've learned a lot over the years, and now we leave a little bit of slack in the distal ends and the lower segments because there's more relative growth and there's a risk, especially away from the apex of the curve. So I think, there's a learning curve. And that's why some of the results that you may have heard are not as good as, you would like. But I think I kind of held back and I took advantage of the other surgeon's learning curve. And I've had my own learning curve as well. So I think we're getting better and better is my point. And rotational prominence 20 down to 6 degrees following surgery. And you can see it there. So Amr Samdani and Randy Betts, they reported on 11 patients and showed good correction over time. With improvement in the curve due to growth modulation. And then Peter Newton, and this is often quoted to kind of talk about how the procedure is very unreliable, but he showed good correction and then a slight rebound, latest follow-up, because some of these were associated with broken tethers and maybe the curve came back a bit, but about a 50% correction. The problem is he had a very high revision rate. So, and only a 59% success rate. But he was an early pioneer of this. He's not as enthusiastic about doing tethers because probably of his experience. And he's a terrific surgeon and smart. But he had a very high rate of problems. And some of these were because of overcorrection. I think a lot of that is because his patients were younger. Almost 80% had open triradiate cartilage. So there's too much unpredictability when you tackle these in patients who have a lot of growth, abundant growth. And plus, there was a learning curve. How much tension do you put at various segments of the spine to avoid these things? So, here's one of the cases where probably it was too big a stiff a curve, a big a curve. Maybe you could have tethered more segments. I would sometimes add a double row so we have more control. But this is what happens in this case and led to a long fusion as opposed to something that could have been much shorter. And then follow-up study, this is now by Dr. Hornschmeyer. Dan was Peter's fellow years ago, and Dan's paper was kind of similar, but the difference is his patients were more mature. 62% now have closed triradiate versus 80% have an open triradiate cartilage. And now his success rate's much better with a more stringent criteria. Curves less than 30 degrees or equal to 30 degrees. So the success rate is substantially higher, although he had some reoperations as well. So, and then when we look at the data from Ahmet Alanay's group in Turkey, we see that the younger patients, Sanders 2, right? Sanders 3 is about when the growth spurt occurs. There's more mechanical complications. So tether breakage, loosening of screws, breakage of screws. I haven't seen a lot of that. It's been very rare, but breakage does occur. And then overcorrection with Sanders 2, 80%. So really it's about the timing, and we're better when we time it right and we tackle the right curves. Here's a case of overcorrection. So you can see it's become this one long curve. And the way you address that is to go at it, to go back and cut the tether or remove part of the tether in these patients so as to avoid this continuous overcorrection. So we looked at an evolution through our research group in the Setting Scoliosis Straight Foundation, the evolution of surgery for this patient population over 3 decades. And we looked at largely the procedures over time. So posterior spinal fusion, VBT, anterior fusion, and this is posterior fusion with an anterior release. But basically what I want to draw your attention to is blood loss per level, per instrumented level. So tether, there's minimal blood loss. I've never had to give a blood transfusion to one of my pediatric tether patients, not one, and I've done more than 500 cases. Even fusions, we've gotten better and better because we're paying a lot of attention. We're trying to minimize this. So this is beginning in 1996. And then when you look at the data, sorry, the formatting's off a little here, but basically major complications, and this is what some of my colleagues have liked to point out, the major complication rates for tether were really high at the beginning. So this is 2006, sorry, 2011 to 2015, and then the second quartile, 2016 to 2022. But you can see the major complications are cut in half. And it's parallel to what we saw with spinal fusion, posterior fusion, almost the same major complication rate at the beginning, and then it was cut in half or better even. So I believe we're gonna get better and better, and we're already showing that. And the same thing here for reoperations. They were sky high for tether. Now, some of these are almost expected reoperations where you cut the tether when the patient straightens out and they start overcorrecting. That's almost it means the procedure was effective, but we really want to minimize the second operation. But some of these were, other types of reoperations like going on to fusion. But again, we've cut the rate in half, and I think we'll find in future studies that the rate will continue to decline. There are a lot of studies now and increasing numbers, so I'm not going to spend time on all of the data. You can read this if you have interest. But essentially, this is a comparison. Peter Newton took the lead. Our patients are in this study as well. Tether versus fusion for thoracic curves. And what we do find from this is that the final curve is a little higher after tether versus fusion, and clinical success, meaning curves under 35 degrees, a bit higher as well for fusion versus tether, and more reoperations for the tether. I think, again, some of that is wrapped up in the learning curve, but also I tell patients, if you have a larger curve, fusion's going to give you a better correction. But is that important to the patient? It depends on what they value more, flexibility versus straight. We looked at tether breakage. That's also a problem, and we saw 1 in 4 patients had a tether breakage in 69 of my patients. 27% had a breakage at 2 years, but still, the clinical success rate, these are curves less than 35 degrees, was still similar in this particular series. We have a lot more patients now, so we'll have more numbers. But basically, most of these occurred in the lumbar spine. So the lumbar spine is more likely to have tether breakage sooner because of the greater forces and range of motion. But we had only 1 reoperation for loss of correction related to tether breakage. So in the lumbar spine now, we double up the tether so it'll last longer. Here's a bilateral tether. It's different than that other patient I showed you. A 15-year-old boy, he had been braced, and we did a bilateral tether on him. And then here he is at 5.5 years, and he broke his tether at every single level in the lumbar spine. But look at the difference. He's got a fairly normal spine, relatively mild curve, and he doesn't have a fusion into the lumbar spine. And he has excellent correction of his rotation. So the lumbar inclinometer measurement went from 16 degrees to 2 degrees. And so I find this time and time again, even with breakage, their axial correction and their clinical rib prominence or lumbar prominence tends to hold. It's an interesting phenomenon. And here he is at that follow-up visit. And sometimes a breakage occurs just in the nick of time. So here was a young lady who was starting to overcorrect, and she broke her tether. and eventually she'll break down here, I think, and she'll be even straighter. So and she's a really highly competitive butterfly swimmer. She had her best time following her procedure. So they still can be quite functional. And I think had she had a fusion in that area, it would have probably ended her career. And here's a patient from that study, the tether breakage study that we did. This is my patient. We did I think our mistake was we did only a single row at that time. That's what we were doing instead of a double row tether. And we didn't address both curves. So she broke, her thoracic curve got worse, and we salvaged it with a fusion of the thoracic. So it's very reliable, nice and straight. And then we added a second row of screws and tethered. She's now a nurse or in nursing school and doing quite well several years later. And then sometimes we'll have some overcorrection that really is fine, and the patient, does really well and has minimal clinical impact, and we didn't have to go and intervene here as she approached skeletal maturity. But unfortunately, overcorrection, this is not my patient, but this is one in our database, and this is not an acceptable result. So that should have been released earlier on, or maybe more likely we shouldn't have, the surgeon shouldn't have addressed this lumbar curve. Should have been maybe just thoracic, and even that, it's a pretty small curve, so I'm not sure that would have been a good case to do. Here's one of my patients. So here's a family. I said we can do a fusion of the upper curve here and tether below, or we can try the tether and see how it goes. And so we did that. Unfortunately, they were lost to follow-up due to COVID, and then came back with that upper curve did get away, especially with some overcorrection occurring. So unfortunately, that was a case where we had to do a salvage, and we fused above and added the tether below. But we saved her lumbar spine from a longer fusion. So I think in the end, that was quite good. And so, but in the end, we really have to compare over time and over the long term, how do our tether patients compare to fusion? And these are similar curves, and the fusion looks nice and straight. I wouldn't want that for my back. But time will tell. We'll study it. We have data on double curves and compared those to fusion in orange. And what you can see for thoracic major curves, so those with a larger thoracic curve, in which both curves were instrumented, the end curve is less for fusion than it is for tether. So it's just data that we use to talk to our patients about. But if you have a major thoracolumbar curve, the corrections are actually very equivalent for tether versus fusion. And just some more cases showing bilateral tether versus fusion. If you like symmetry and perfection, you maybe get it closer with this, but I like flexibility. So, but we talk to the families and give them the choice. There were more major complications. Again, this is part of the learning curve. So in tether versus fusion. So now switching gears to mature patients, where we didn't start doing the mature patients right away. We kind of tiptoed into it as we gained more experience. And so certainly patients who have a desire to preserve their lumbar spine for the flexibility and hopefully to avoid the disc degeneration we see after fusion, we started applying this to smaller flexible curves, and some growth may be better than none. We double up the cord, both in the lumbar and even now the thoracic, to give it more durability. So it's going to last longer. Eventually, we're going to have much stronger tethers. So we're going to be able to push the envelope more and more with tethers that will last for years. But the data has been somewhat limited. And so the Hoyt or Volkmann principle is growth modulation. That's where you get less growth on the convex side, where you're compressing the growth plates, and more on the concave side. But there may be some remodeling that occurs for the soft tissue, the disc. And Wolff's law is the law that governs loading of bone and how the bone remodels. And so I think especially if we have stronger tethers, which we will, Stronger tethers are going to be coming out in the next few months, and even stronger, I think, in the years to come. But our patients tell us why they chose VBT. I want flexibility, growth, minimal scar, shorter recovery time. I can always have a fusion, but I can't go backwards after having a fusion. And lumbar fusion can cause adjacent segment problems. And some end up with fusion into the pelvis. That's exactly what I showed you earlier, limiting mobility. So the families are very, very well educated, and flexibility and minimal scarring were the main factors, etc. So here's a patient who's on the more mature side. She's a RISSR 3, almost a RISSR 4, proximal humerus ossification stage 4. So she's well beyond her growth spurt. And her curve's large side, especially in the lumbar. But we did a bilateral tether. We doubled up the tether in the lumbar spine. And we did what's called an annular release, a disc release, where we just cut part of the annulus at in the thoracic spine. And that's controversial and I think should be limited. But in this patient, we did it and provided an excellent correction. And you can see the nice clinical result and excellent scores. I circled pain there because despite doing the annular release, she has really no minimal pain. So 5 is the best score you can have. And here, a mature, relatively mature patient, again, we doubled up the cord in the lumbar spine with a very nice correction. So we've published on this. Again, you can read this in, if you'd like, you can go back to this, but essentially the patients who were mature versus immature had slightly less corrections. So the percent correction is going to be less because they're not able to straighten out with growth over time. But, you know, the patients look pretty good even in the mature group. And nowadays we double up. We use a second row of screws in the thoracic spine even, and certainly in the lumbar, so that it's going to have more durability. And we had another study that we published on almost 50 patients, also mature, so on the mature side. And we have now a follow-up paper with, I think, minimum 5-year follow-up that we're working on. So we're going to have, you know, this is really all about data, but basically the patients have done pretty well overall. But this is what it looks like, you know, so here's a single row. Now we're doing a double row, but when they break, the curve partially returns. But at 2 years, this patient's doing pretty well at 18.5 years old without a fusion into the lumbar spine. And again, the double rows I think are very important. And just some comparisons of the immature patients which grow and they kind of can overcorrect a little bit versus just you know, the mature patient where they're not going to have that overcorrection. So in some ways, the mature patients are more predictable. Now, if we can have their tethers last forever, they'll be even more predictable. So again, immature top versus mature. Now, to switch gears, we'll do a lot of hybrid approaches when the patients have certain criteria. So if the thoracic curve is very severe, if there's thoracic lordosis and we have a desire to restore kyphosis for its impact on the cervical and lumbar spines, if there's a large rib prominence, we don't necessarily have as good a correctability of the rib prominence with tether versus fusion. And triple curves, you really have to address the proximal curve with a fusion. There's no way to do that with a tether. So we can do these hybrid procedures. Here's another one. This is the patient with thoracic lordosis. Unfortunately, the neck's cut off here, but she's got a very straight cervical spine. And then we restored kyphosis and tethered below. I just saw her at her 3-year follow-up. Future indications include cerebral palsy, for example, in this patient, and other indications. I have some other neuromuscular scoliosis patients that we've applied this to, and this is a bigger curve, but it was somewhat flexible. And over her follow-up, she's got a really nice correction. She's about 3 years out now. What about adults? We don't have to go through all of the data here, but basically the adult scoliosis literature, it just really shows a kind of not the best track record. A lot of these patients do super well after a fusion. They have improved pain, they have improved function, but they're also stiff. But there are very high complication rates, reoperation rates, neurologic mechanical complications, broad breakage, proximal junctional kyphosis. So we don't do a great job with fusion for those patients. So with my experience in tether, and I had one of my earlier patients who was an adult, 43 at the time. She knocked on my door. She came from I think there's a physical therapist in this session from Louisiana. Well, this lady came from Baton Rouge, Louisiana, and she went around to see my colleagues, and we all offered her a fusion. She went around to various surgeons in New York, and then she asked me. She said, "I know you do tethers. What can you do a tether?" Well, I tried to talk her out of it. I said, "Well, we can do this." So we did a double row tether. We just published in Journal of Bone and Joint Surgery Case Connector, 6-year follow-up. I saw her a few weeks ago, and she's now 7-year follow-up. She's age 50, and her tether hasn't broken. She's holding up really nicely. I think this is going to become an indication, especially as tethers get stronger. And the rationale for this, I'm happy to answer questions about any of this, but we can talk about it. And here she is at the 7-year follow-up. Her pain and all of that improved. She basically she says, "My back's not perfect, but I'm really happy and I'm doing really well," which is what we want to hear. And that's her along the way in her clinical result. Here's a 41-year-old patient of mine who also was offered fusion by many, including myself, and she has already, before surgery, a lateral listhesis of L4 and L5. So the L4-5 disc wasn't great, and I think none of us would have offered her a fusion to L4. We would have had to fuse to L5, and then the L5-S1 disc would not have much longevity. So after much discussion, we tethered her, and she's doing quite well. She's almost 4 years out now. And here's a 41-year-old anesthesiologist from Philadelphia area. I don't have any further follow-up. She kind of disappeared, which probably means she's doing well. She was even hyperkyphotic, and just by tethering her and derotating, her sagittal alignment improved, which was really nice to see. But half a year out, she was doing quite well. And then here's an early one of my patients as well. She was 55 years old. She's an attorney from Chicago. A lot of back pain, even sciatica. So she had, and some degenerative changes as well. And I offered her a fusion, and she said, "I'd really like a tether." So I said, we could tether the main curve and then fuse below. And she said, "Let's just try the tether." So we agreed to it. And sorry. And there she is. So not a perfect correction. It was a pretty stiff curve, but this is her 3-year follow-up, and she refuses to send me x-rays. She's about 7 years out as well, and she doesn't want to send me x-rays. I think she's afraid to see a tether break, but she does report to me. She says, "I have no pain." And she's back to working out. This is her. She's a bodybuilder. Always making excuses. So I'm just going to show you, I'm going to end this talk by just showing you kind of no fusion or less fusion options, just as a summary. This is how we always used to do these cases. At the beginning of my career, we'd fuse everything, made them nice and straight, and surgeons are all proud and the family's happy, but then they come back to see you years later with problems. So we don't do that anymore. If we're going to do a fusion, if that's all we have, we try to do a selective fusion like here. So left most of the lumbar spine alone in this particular patient, and that's selective thoracic fusion. And we're also starting to shorten fusions by tethering below it. In this case was kyphosis, which we can't treat with tether, but we fused and then addressed the additional thoracolumbar scoliosis with the tether below. So we shortened his fusion. And again, the hybrid fusion tether for large thoracic curve, and then you can tether below. Here's an apical fusion where we can take a curve in a mature patient and fuse at the apex. There's a cage there, and tether across it. And, of course, then there's just tether. And here's a patient, the curve is larger and a bit stiffer, so we put a double row at the apex. And with growth modulation, the patient corrects very nicely. And here's a lumbar tether. We showed many cases of that. This is with 6-year follow-up. So, and there's a break here, by the way. It looks like those screws have splayed. So even with a break, the patient has a very nice correction. So I think with this procedure, it relies on growth modulation, although we're pushing the envelope into mature patients. I think there's a lot of promise of this procedure. We get correction. The patients who are growing grow. Their flexibility is at least partially maintained. The long-term results are going to be key, and we're going to make improvements in our techniques and in the implants themselves. But I think for me, avoiding fusion or shortening fusion is really important, and I think the skeletally mature population will become a significant indication, especially for lumbar spine. Particularly as the curves are made strong, as the cords are made stronger. So we're not burning bridges, and we're really approaching this with our eyes open and looking for best solutions for our patients. So I'll leave it at that, and I thank you for having me.
Thank you very much for this very intense and informative session on VBT. I'll let Hagit speak for a minute, and I have a couple of comments for all the physiotherapists here. So before we do the questions, Hagit, do you want to say a word?
Yes, can you hear me?
Yes.
Okay. Thank you, Beron. This is a very informative, and we have a lot of questions if you are ready for that.
I am.
Good. Andrea, before asking questions, anything you want to
Yes, I just would
talk
like
or
to.
share?
Yeah, thank you very much. I would like to talk to all the physiotherapists, orthotists, and medical professionals who are taking part of this very important topic, that to keep in mind Dr. Barron's main message here, that the patient have a say. The patient have to have an educated consent for the treatment, and a patient has to be discussed with all the options, not just physiotherapy and bracing, but also the surgical options for the care. So I feel that I wanted to share this comment with you because I see a lot of VBT patients. I recommend the VBT for the patients who are in that category. And unfortunately, in Canada, we have a different selection criteria. And if you wanted to check the Canadian criteria, you can check Dr. Al Hawari's lecture in our library. We're looking at research zeros and ones. So we have a lot of overcorrection, a lot of tether breaking, and a lot of unhappy patients who come out without a good aesthetic because we don't have ASC. So we have a different population here. But you check your local guidelines, check your local team, and work with the team, because we also work with a lot of patients post-surgical on the posture, on the conjunction zone, on the tether breakage before they make an educated consent for the next level of care, which could be fusion or selective fusion. So I would like to tell that to all our visitors here, no matter the background, which school you learned from, Schrott or Leon or any background, work with the team very closely, because you have a small window of opportunity for this type of procedure. Ideally, now it's a larger window with the adults coming on, but important that you don't close any doors, don't burn any bridges for your patients, and inform them very thoroughly of all their all the options, so they can elect the educated option for their future, for their child, for their teenager, or even an adult. And Ian Stokes' lecture is also in the library. So if you're interested in biomechanics, please visit the library. And we have a lot of other surgical lectures in the library. So I just wanted to share this message before we have this question period, because I feel that physiotherapists sometimes may be, or even orthotists, we're holding on to patients a little too long, and they may be eliminated for the optional surgical interventions if they are not aware of it. And it's very sad for me sometimes to sit and tell the patients, please don't see me, because if you improve, you are not going to be in a surgical criteria anymore. So they have to still go home and discuss it with the families, and they have to make an elective, a very free, open-minded, educated consent for the next session. So I wanted to just share this message to everyone. I'm not sure if you want any comments on it, and we can go on.
Can I make a comment,
Sure.
Andrea? I think that's very, very important. And first of all, almost every single one of my patients, I would say 90+% go to a Schroth therapist after surgery for this procedure, and even fusion. I send them to Schroth therapists. Some of them don't have access to Schroth, so they go to a physical therapist anyway, but not with this expertise. So I think it's very important that we work together hand in hand, both prior to and after surgery. Um, and I do think it's really important. Our patients are very sophisticated, so I showed a lot of data, and I didn't do that to bore everybody. I did it to just show you that there is data, and in some surgeons' hands or in their community, they have limited indications. But I'm looking at my own patients, my own data, and I try to do it as skeptically as possible because we want to know where we're doing a good job and where we're not. And we've sometimes pushed the envelope too much. So where we got into trouble, it was larger curves in the thoracic spine, single row tether. They didn't hold up very well. We didn't get enough correction. And the patients and the families, they're not angry at me because we talked about it very much in detail. And I feel badly about it, but we learned a lot. So I think for all of us, physical therapists, surgeons, whatever, we look at our data, look at the results, and work hand in hand, and we'll have happier patients.
Yes, very, very important. And I really appreciate your honest presentation with the goods and the bads, or what we have to improve on, because sometimes VBT looks like the next rosy choice. And it is important to learn all aspects of the surgical procedure before the election, and what is best for the patient. Discuss it with the team, definitely discuss it with the surgeon, have lots of questions and to the surgeons, and we also have lots of questions to you here. And we just touched on the neuromuscular scoliosis, but we do have that type of question, if the neuromuscular scoliosis patients will have access to this type of procedure. But also, Hagit, you can start up on the questions in the Q&A board. So just a quick on neuromuscular, and then we go back
Yes.
to AIS.
So I think that the indication is for adolescent idiopathic scoliosis, but we've been able to push the limits here in the United States and in my practice. So I have a handful of patients. I have this young lady with cerebral palsy. Now, we're not going to be able to apply that for someone who's got a lot of spasticity because they're probably not going to hold their correction very well and break the cord. And also very severe curves in general don't do well, although that young lady I showed had a very nice correction and she's done really, really quite well. She's very high functioning. We have arthrogryposis. I have spinal muscular atrophy. I have Nemelin rod myopathy. I have myelomeningocele patient. So we have a mix of patients with some neuromusculars, but the main indication is AIS.
Thank you very much. Hagit, do you want to start with the questions, and I'll check the end of it just to make sure we don't have duplicates.
Sure. So there are patients, let's say, with 60. This is from a mom who's asking, a 60-degree curve in a 16-year-old, probably Sanders 7-8, probably Sanders 8, with a 60-degree curve. It's a thoracic primarily. It's a thoracic curve.
Yeah.
I think lanky one. And the girl is active in sports, doesn't have any pain and complaint. And the parents are, and many families come like that and asking, okay, mature, finished growing, 50, 60 degrees, active girl, afraid to do fusion, but no pain, no complaint. Yes, body image or body shift, pelvis and trunk. It's not a balanced curve. It's just there is the shift. First of all, is tethering, taking care of the body alignment, like fusion. Even though in fusion too, sometimes we have the adding on phenomena, and then the pelvis all of a sudden runs sideways, even in a balanced curve. Is pain have to be there in order for a family to seek for surgery and on a 16 years old? I think it's not about the pain, because anyway, we lecture all the time that there is no correlation directly between scoliosis curve size and pain, according to the ups and down literature, but this is not it. And definitely 16 years old usually don't have pain if he's healthy, emotionally, mentally. What do you think? I know I
Yes.
added a lot of
No, I know,
points
and I
into
see
it.
those patients very frequently, Hagit. It's a great question. So I always give them the options. So I say, and first of all, a lot of the patients don't have pain. Some do, but many of them don't. But so one, two, a lot of them have self-image concerns. They really don't like the way their back looks and they're embarrassed by it. Some don't care. Some are not bothered by it at all. Um, and some really want nothing to do with surgery. So all of those are put in the mix. But we often treat,
Right.
we've often done, and I've done probably hundreds of fusions, and probably the same for VBT, or maybe even thousands, all told, with patients that didn't have pain. Maybe they didn't like the way they looked, but we were concerned about the natural history of the curve getting worse over time. Some of them are mature. So I think it's important to say, look, you can delay this, and you may end up with a longer fusion later in life if you delay it into your middle age years, or you can do it after college if you're a swimmer, for example, and you can have a fusion. So the fusion is the standard operation, and we always start with that. The advantage of fusion is you're going to get a great correction. It's reliable. It's going to be Fort Knox. It stays there. It's there. And we'll probably get a pretty good correction of your rib prominence, your body shift. You're going to look good, but it doesn't move.
Can we ask you regarding the rib prominence, because it's connected?
Yes.
A therapist asks, how is the tether taking care of the horizontal plane?
Yes. Because, and even that Frank Schwab animal study that I showed you, and there was an improvement in the axial rotation. It's because spinal motion is coupled. And when you correct the coronal plane, they derotate. Even so, just the correction of the coronal plane results in a derotation. And it's very powerful, especially in the lumbar spine. We don't do as good a job derotating necessarily in the thoracic, but in some cases we do. So if the rib prominence is a very big problem for the patient, I'll say to them, we often do get good correction with VBT, but it's less predictable than with fusion. If it's more moderate, I think it's equivalent for both. But so I said, if it's really important to you, then probably fusion is the way to go. So for these mature patients, some of them say, I really want this fixed or corrected, but I don't want a fusion. I have done thoracic tethers, and we use double row. If it's flexible enough, we get them nicely corrected, and it's definitely different than a fusion. It's the patient is different. And the recovery is easier, but their spine is different. It's more natural. When you put a double row in the thoracic spine, it's going to stiffen it some. It's not perfect, but it's shorter. It's so less segments involved, good corrections, some flexibility, and they're looking pretty good. But we only started doing double rows routinely a couple or 3 years ago, so we'll see how it plays out. But I think they're doing very nicely so far.
Thank you. Is there any extreme physical movements or sport even that may interfere with the success of the surgery after tether?
Yeah. So many of the patients are very athletic, dancers, swimmers, cheerleaders, lacrosse, soccer, basketball, whatever. I let them play their sport. They often ask, will this be a problem? What I say to them is, the more you do, the more mileage you put on the tether. So it's going to, maybe more likely to break. But part of the reason you have this type of surgery is to preserve your activities and your function. So we let them do this. I would say the sports such as swimming, where they're doing flip turns constantly, and gymnastics, etc., will probably have higher tether breakage rates. But I think with the doubling up of the tethers, they last longer. The adult patients that we've operated on, their activities are less, and we're kind of stabilizing their spine while their discs naturally stiffen and the segments degenerate, and they go through the degenerative cascade is one of instability at the early phases, and then it kind of stabilizes as the spine becomes stiffer, and that's the concept for the adult patients. But
Right.
I've had some dancers and whatnot that had early tether breakage, at least one patient that I know of, because I just looked at her case yesterday. And so it does probably put more mileage on it. But with the double tethers and just counseling of the patients to let them know it may not last as long, they're aware. But tether breakage doesn't equal reoperation. You can lose some correction, but so far in my practice, the reoperation rates have been very, very low.
And how long does it take for the autofusion, if we want to call it, after tethering, where I believe I let you answer, but I believe it depends on the age,
Right.
in terms of autofusion, auto-fixing, where it doesn't really matter if it breaks because we reduce the curve as much as considerably possible, and maybe below 30 as a goal, because we know that after 30° we have more risk of progression. How long does it take for the tether almost like to autofuse itself? And do you spread any bone
Yeah.
during the surgery?
We don't put any bone there. I don't think they fuse, but I do think they stabilize, especially, I have a few now of middle-aged adults. I think they stabilize sooner. And the key is, and this is not at all an indication, we have that one publication, but we're going to study this. And I believe that there will be, this is a group of patients that would benefit tremendously from this approach. So I think for the adults and mature adolescents, they are different. The adults have already disc degeneration, and they're going to stabilize. And I think that takes a few years. But they're also not putting as much mileage on their tethers, so they'll last longer. The younger, the adolescents, the younger patients in their 20s, those I think will take longer to stabilize. So I think they're not fusing, but they are stabilizing. Even with tether breakage, the mature patients have been largely holding up. The reoperations, I think, happen when there's a larger curve left behind, or a larger curve to start, and we're not getting enough correction. So I think we want to get them as straight as possible, even less than 30°. But I think really what will happen is the tethers, when they become stronger, and the engineers tell us that they could be 3 or 4 times stronger than what we have now, So it's going to last for years. It still will break at some point.
Right.
But if we can hold them for years and years, even when the breakage occurs, I think those adolescents will be terrific. So the patients that we're offering this to now, largely they're holding up, but I always tell them, we don't have the long-term follow-up, and we have to assume that there's a possibility your curve will come back. And if you're in your 20s and 30s and the curve is partially recurred, maybe it doesn't bother you and you do nothing. Or maybe, you, my curve is back, it bothers me. I like my correction, but I like my flexibility. Well, then we can put in the stronger tethers. So you have to go back, of course, and do a reoperation, but we would just leave the main screws in and just place the new stronger tethers. So that could be in the future, a salvage, or the patient can always have a spinal fusion. So at least with us pushing the envelope, we haven't burned any bridges. The patient still has their spine, and the hope is we'll have better implants that will last longer in the future, and this becomes more of a standard approach.
Right. Yeah, it's in my feeling and hope. Yes, it started for like as an internal bracing for teenagers who, for different reasons, cannot really brace themselves. But it actually shows, right, that too early is too early, and actually pushing the envelope. I'm advocate like you, with the knowledge that this is experimental, but still with enough case studies. So and it's somewhat an option for adults who debating. They definitely don't want to do fusion. If they have like this notion not to fuse their body, but they don't want to stay without anything. So this is almost something to do about that is less invasive and more hopeful.
Yes, well, it's interesting, Hagit. I have a lot of adults, even in their 60s, that reach out to me, and I'm starting to consider some of them for surgery, as long as they have good bone density. And
Right.
one lady from Oregon said to me, she's 66 or something like that. She said to me, she says, I'm too young for a fusion. And she says, I'm active, I'm constantly moving. I'm too young for a fusion. I totally resonated with me. Her bone density is good. Her spine is very flexible. We're gonna do that. We're gonna offer her that. So, which I would, even for me, I would never have even considered that. I would have thought it was crazy if somebody approached me 5 years ago, and I would have said any surgeon doing that or offering that is crazy. But now I think it makes all the sense in the world. So we'll have to do studies going forward, prospective studies that are going to be very expensive to do, but I think that will be the ideal. And I believe we could have an
I hope
application.
so.
Yeah.
Right. Is there any limitations? I'm not sure if the word limitation here is the correct one in the question. Is there any limitations for not abusing the free segment below the fusion segment? Is there any limitation for not abusing the free segments below the fusion segments?
Right. So fusion patients, it depends on how low you fuse. So if I've done a selective thoracic, maybe I'm at L1, maybe T12 or higher, I pretty much let the patients do anything they want. If we fuse to L3 or L4, I think letting them do everything, for example, lifting overhead where we're loading their spine, a lot of heavy lifting, um, they're not going to be able to do gymnastics reliably. They'll put too much strain on their lower lumbar spine. So gymnastics is generally out. They can swim, but they're not going to be able to do flip turns very well. They may be able to do them at some point, but that's going to really put a lot of load on the discs. So I'm not fusing the lumbar spine very much, almost never nowadays. Um, except for
Right.
adults that have very bad degenerative disease and spinal stenosis. We'll have to fuse those sometimes, or just decompress without fusion. But I try to stay away from it because I think there are limitations, and those patients do get into trouble. So heavy lifting, activities with a lot of motion, such as gymnastics, some dancing, things like that.
So there's a
Very
couple.
good. And I want to share with you that we feel and we guide us as physical therapists, particularly Schroth. Um, Maybe I will start by saying many people think that once you have a surgery, no matter what's the surgery, you can go ahead and do what you want. And or that's about surgery. Also in physical therapy, people, we guide them. I want you to know that we guide them with the surgery or without a surgery, that sometime, not sometime, you have to modify your activities. It's not that, and they need to understand, like, not just because you have scoliosis, there are there are different kind of spine degenerative changes, different conditions where you cannot fix it completely. This is it. We have alisthesis, we have a lumbar curvature, we have the modifiers of Schwab that, we know them. So you need to limit your activities. Even if you had a surgery, respect the area that tends to be unstable,
Yes.
and modify your activities. So you're not going to go back and be a super athlete. Yes, you give up on, but you get something else.
So I agree with that, Hagit, but I also put it to the family and to the patient. I say, if you do more of this, if you have a tether, maybe the tether will break sooner. But if that's what you want to do, it's your body. You may lose some correction. You may need another operation. Uh, but if you want to modify it, then maybe it'll last longer. Same thing after fusion. You can do this, that, or the other thing, but if you do it, you're going to put a lot more loads on the lumbar spine below, and then you may need an extension. But I said, on the other hand, if it's the most important thing in your life, then go ahead and do it. But just understand what the
Right.
impact is. That's kind of how I talk to them about it.
Like hip replacement. The more you use it, you will need a revision.
Correct.
And there's a connected
Excellent.
questions to this one here. When would you choose to actually fuse to the SI joint yourself? I know you're not doing it often, but when would you have that criteria? I think it's connecting to this question, and also for VBTs, is there any hyperkyphosis developing after VBT in adults? So if you can answer some adult questions in this would be very good.
Yes. My pleasure. So the long fusions that we do and I still do them occasionally. I don't love doing them, but the patient has big curves, thoracic and lumbar. They have a lot of degeneration. They may have spinal stenosis. There's no choice but to fuse the whole basically upper thoracic from T4, T3 down to sacrum, and then we put the pelvic screws in that cross the sacroiliac joint. And that's a very, very big operation. Unfortunately, their pathology, their disease dictates that. Um, we're finding there may be some cases where we can do a lumbar tether, but the older patient, poor bone quality, you're not doing tethers on those patients. And again, it's not a standard indication. It's not an accepted indication. We're just pushing the envelope for very select patients. But I think the pathology is what dictates it. In terms of hyperkyphosis or proximal junctional kyphosis, so some of the adults, it's almost an epidemic after adult spinal fusion where 15 or
Right.
20% will develop PJK, proximal junctional kyphosis. Now, sometimes it's not symptomatic, sometimes it is, and sometimes it needs a reoperation to address it. So it's probably very multifactorial. It's related to how much correction we get, especially in the sagittal plane. if we overcorrect, if we undercorrect. It's related to the patient's physiology, how healthy they are, how good their muscles are, how we handle the ligaments above the fusion, if we cut them, if we uh, don't preserve them. So there are a lot of factors, and it's been studied very extensively, and we don't really have good answers. And I think so for some of the adults, we shouldn't operate on them. I think we do too much adult surgery, in my opinion.
Thank you very much. And is this VBT surgery you might be doing for adults, does it interfere with any pregnancy or during labor, giving any epidurals? That's another question here.
Yeah, that's a great one. Uh, so I have had, I think, two patients who have given birth after having VBT. There's no reason to be concerned about their ability to conceive. We used to do a lot of anterior fusions as well. So I've had many patients give birth. So there's no impact on their ability to conceive. There's no need to have C-section based on the implants. That would be independent of that decision, which should be independent of the surgery. And they can have an epidural because the back is untouched, so there's plenty of space for the epidural.
Thank
So is a
fusion
question here about the
sorry.
the topic of the disc release.
Yes. So disc release
When is
done,
it necessary?
yes, I think it shouldn't be done except very, very seldomly and very selectively. So I showed that one patient, we did 2 or 3 disc releases in her thoracic spine because her curve was too big. And the only way we would have gotten correction is by releasing the disc. So it should be used, first of all, it's not an accepted, standardly performed. So I would always, and I tell the families that. Many of my colleagues think it's not a good idea. And I would agree with that in general. But we do them in the thoracic spine when the curve is large. I've done them occasionally in the upper lumbar. But I think if you cut a disc, even if you stick a needle in the disc, there's a high risk of disc degeneration after that and back end or leg pain,
Right.
sciatica. So we have used them almost always in the thoracic for a large curve. And what I tell the families is one of 3 things will happen. It can potentially regenerate and it'll be fine. 2, it can stiffen a little. 3, it'll fuse. And actually the fourth is it can become painful and be a painful disc. But in the thoracic above T10, it's pretty stable there. So I think they probably stiffen up and we haven't seen problems. But I do it in less than 5% of my patients. There's a group not just across the river from me that cuts every single disc, lumbar, thoracic, and as if it's a party. And I think that's a big mistake. And
Right.
some of those patients are going to have problems in the years to come. So that should be rarely done, very selectively with good education of the patients that we don't have long-term follow-up. We don't know how how those discs will fare over the course of time.
Thank you. And could you comment on hypermobility in adults as well as the lung function or bone health? How does it affect or changes your decision making for offering VBT or fusion surgery?
Yeah. So the hypermobile patients actually correct very well. So you can get them nice and straight with the tether. I have had a few Ehlers-Danlos and others, and they correct nicely. So that hasn't been a problem. In terms of bone density, this is a motion sparing operation. So if the patient is osteoporotic or they have significant osteopenia, and you put a screw where there's motion, the screw is going to pull out. So I wouldn't offer it to those patients. Even same for adolescents, they have to have good bone density. So if there's any question about that, we do a bone density assessment and would not offer that to them. We do have some adults who are really interested in this. And I said, well, you have to be on the medications to improve your bone density. and we could consider it. But I think it has to be very, very super selected to patients with good bone density, good relatively healthy discs, and we're not doing them that often in the adult.
Thank you. We have a question here. It's probably from United States. If you want to quickly answer regarding the insurance companies, if they're covering these surgeries.
Well, we have to be creative with the insurance companies, and we have been able to, by being creative, get cases approved, but I would leave it at that for now. I think in the future, my hope is that there'll be some prospective studies that then makes this a mainstream and accepted approach where the insurance companies, they're all about profit. They don't care about patients. They really just care about profit, in my opinion. But I think the insurance companies will become more profitable if they have less fusion and more tethers, especially in the mature patients, because they don't overcorrect, so they're very predictable. The one issue for the mature is the breakage and then loss of correction. So I think if we have stronger tethers, these are going to be very, very predictable outcomes and better than fusion.
And I would say, we invite anybody who's talking about or asking questions regarding lung function and surgery to watch Dr. Gregory Redding's video in the library. It will be a lot more questions answered that way. Do you see any unanswered questions, Hagit? I think we managed to do most of the questions. If you are missing any answer, please email us at ssolglobal@gmail.com. We had many, many questions here, so we tried to answer most of them. And if we missed you, please email us and we connect you with Dr. Baron Lohner. He will be happy to connect with you regarding any surgical questions. And I think that would be the easiest way to get your answers for individual cases and individual conditions. I want to thank you very much for coming and presenting for us with a hot topic like this. And we had a very successful webinar. I know Hagit would like to also say goodbye, and we hope to see you very soon because based on all the questions, we have a lot of interest in the VBT surgery. So it would be nice to see you back soon.
It would be my pleasure, and thanks so much for having me again. And I'd be happy to answer other questions. By the way, just a quick answer, the pulmonary function. If the patient really has a very severe or significant decline in pulmonary function, we're not going to do the VBT because we're entering the chest cavity, so we wouldn't do it in those patients. But that's rare in this patient population.
Right. Excellent. Thank you so much. And maybe we'll do a follow-up session where people can actually directly ask the question. So you'll meet on a big screen people, right? Because they say, but yeah, it's very detailed.
I would enjoy that. That would be fun.
I'm sure, right? Yes, it will be great.
It'd be my pleasure.
Okay, thank you for your Sunday time.
Thank you. See you everyone on July 13th when Hagit is going to present on the upper thoracic curve. And have a great summer after that. And we will be back in September. Thank you, Dr. Baron, and thank you everyone for joining us on a Sunday. And stay safe and well. Bye-bye.
Be well. Bye-bye.
Bye-bye. Thank you.